Welcome. Thank you all for joining us today. I am super excited to introduce Colleen Goethals. Colleen is our Vice President of Mid-Revenue Cycle. She flew all the way here from Chicago. She's fantastic to work with. I think we've worked together for about 10 years. She's just amazing, and I'm so thankful to have her here to speak to you today about denials management and denials prevention. She is also a past AHIMA board member and past president director of delegate of the Illinois Health Information Management Association. She has spoken at Becker's and several different AHIMA and HFMA events, and she's also recently won some additional awards, which I'm afraid I will mess up, so I'm not going to tell you about them, but she's a wonderful person, and we're so thankful to have her here today. Thank you, Colleen.
Thank you. All right, a couple things. Number one, I can't believe you wouldn't want to be with that Jerry guy because he's like really cool. You know, I was like, oh, I hope I can go to his presentation. Then I saw that it was same time mine, so maybe we could do this in 15 minutes and we can run over there. I don't know. But anyway, he was great this morning, so it's hard to follow that guy, that's for sure. I'm also doing this with one contact in, so I can't see the room over here very well. So I apologize in advance if anyone's raising their hand, flipping me off or whatever. I'm not going to be able to see you, so feel free. That's what happens when you get old, right? But today, I really want to thank Oregon HFMA for inviting me. As Teresa introduced, my background is Health Information Management, HIM. I have for almost 40 years lived in that HIM world, AHIMA, and all that world. HFMA is fairly new to me over the last 5 years, and I'm loving you guys. It's wonderful to speak at your events and learning a lot about what you all do. It's also, I'm going to be completely honest, because I am probably a overly honest person, a little intimidating to be in a room with CFOs, CEOs, and things like that, because I do live in my HIM world. We're the middle child, often forgotten, don't really know what we do. My husband, I've been married almost 37 years. He has no idea what I do. My kids don't know. They think I'm a lawyer because I read the Federal Register. I do read the Federal Register. I know it's boring, but someone's got to do it, I guess. But anyway, again, I thank you very much. This is an hour and a half, which is a long time. We'll probably end a little early, but I do want to make it a little interactive. So if you do have any questions, please let me know. So let's go ahead and get started. Make sure I'm doing this right. Okay. So I typically have in the past spoken about HIPAA, release of information, HIM type of stuff. Then I got into leadership talks. I do a lot of leadership presentations, change management, all those things. But a couple of years ago, I decided to start doing some research on denials because, as we all know, it's a hot topic. And even a few years ago, it was really what I felt getting out of control from our customers that we were dealing with. And I'm like, this is a problem I can solve, right? So I started doing research. And I don't know, I think it's solvable if we maybe start all over with a new payer system. No offense to any payers who are here. But I just really got into it, doing research. So I'm constantly reading about this subject. And the more research I do, it all says the same thing, besides that it's getting worse. Every year it goes up a little bit. We'll talk about that in a minute. But every article I read, every speaker I listen to says the same things. Identify your denials, understand what your problems are, do analysis on them, and then address the problem, right? So I took all that information, and I'm constantly taking that information and updating this presentation. And today, I do want to talk a little bit about the impact of denials. Some of you are living it day in and day out, I'm sure. Looking at denial rates, the root causes, the workflow analysis. We'll look at the coding focus too. I know that this may not be the group that you're in charge of coders or whatever, but I do think it's important as we delve into this a little bit more just to talk a little bit about how you can make sure your coders are coding appropriately and what those implications are. Even though that's my background, that's where I started almost 40 years ago as a coder in I-9. Probably half of you didn't even know that existed. My mom was an HIM professional and she coded in I-8. So come a long way since then. But I always want to say coding cannot be the problem. But the reality is sometimes it is. So we'll talk a little bit about that. I'm also going to give you some tips about writing successful appeal letters and then measuring success. Clicker. So despite all the efforts that we all put in and day out into send out a clean claim, denials is inevitable. 89% of health systems have seen an increase in denied claims just in the last 3 years. That's practically everybody, right? 15%, when I started doing this, 11% was the percentage. 15% of hospital claims are initially denied. Those are those initial denials. I haven't been able to find statistics on the subsequent denials yet, but that is a 5% increase, like I said, in just a few years. That equates to approximately $3 billion in denied claims. And that's all claims, right? It includes everything, your prior auths, which we'll talk a little bit about, pre-certs, everything. It's also been identified as the reason for the surge in your over 90 days because of the length of time it takes to mediate all these things. 90% of those denied claims are preventable in theory, right? You can say, oh, right. As soon as you figure it out, what do payers do? They think of something else to get you. But only 66% are recoverable. So you got 90% of them are preventable, but once you've got a denial, it's very tough to get it overturned. And so only 66% are recoverable. Thus, preventing those denials as much as you can, it's not going to be 100%. Like I said, in my little perfect world, I would love that to happen, but it's not going to happen at 100. We're not going to be able to prevent them all. But if you can put efforts into preventing it instead of just managing it and working them, you can turn some of those numbers around. There's also studies that say only 35% of providers appeal, but do appeals. And the primary reason is that it's very expensive, a lot of administrative costs. We heard in the CFO panel this morning about how high administrative costs are. That's true. And it's very difficult to have enough staff and have the right staff in order to work these appeals. And many of them aren't appealed at all. So it's very costly. It can take up to 51 minutes, strange number, so let's just say an hour a claim. Some are less, but some are more, to rework that. So that administrative time is just crazy. So at our company, we work with a lot of different organizations where we do this drill down, and we find that they just don't have that staff to do it. And at one of our facilities, they recently did a conversion to Epic, didn't even build a proper denials work queue. So they were going all over the place. And we found that previously in the old system, they were just adjusting them off. They weren't even sending to us or to anyone to even work that appeal. So now all of a sudden, since January, our number of appeals have gone through the roof where I'm having to hire additional staff to cover it because they finally figured out, oh my gosh, we shouldn't be adjusting these off. We should at least be looking at them. And so, I thought that facility actually had a pretty good system going. Not so much, unfortunately. So we also see that last year, there was a study done that CFOs, and so those of you who are CFOs in here, maybe you were part of this, that they're getting more aggressive in challenging these claims. And some even said it's their highest priority. I don't know if you would all agree with that, but the money that's being lost, the cash that's being affected, like I said, I'm this Pollyanna sometimes. I wish I could change it to say, this is ridiculous that we have to fight all this. I was actually at Idaho HFMA last year, and there was a panel of CFOs, and that's all they talked about right before my talk. And they're talking about, going to the hill and doing all this stuff. And I'm like, yeah, I'm right there with you. But then I had to do this presentation. I felt like, oh gosh, I really hit a chord there. But anyway, higher priority. It is very, very critical that we get a handle on this stuff. So again, providers spent, this is just more statistics, providers spent $20 billion in 2022, I don't have any more recent study than that, pursuing delayed and denials from payers. And it costs healthcare systems $10.6 billion in wasted time and money just arguing in the claim, arguing over those claims to get paid, which the average cost to fight them, they say, is $44. I think that seems kind of low, but then you multiply them by the number of denials you get, and it adds up quickly. And the average takes 3 rounds. It's like a fight. It's like you're in a fight, right? Literally. 3 rounds of reviews with the insurers to get the denied paid, or the final determinant there, which is about 45 to 60 days in each round. So 90 days is not uncommon for you to not even know what's going to happen with your claim. And then you're already at your over 90 days cash just sitting there and waiting. So equaling declining cash. So the average denial rate by the payer is, Medicare's at about 8.4. I thought that was a little low, but this is a very recent study I found this at the beginning of the year. Medicare Advantage, 15.7, probably no surprise there. Medicaid is around 15%. I work a lot in Illinois, and 15% is actually a little low to some of our customers that we have for their Medicaid denials. And then commercial is all the way up to almost 14%. That's huge. These are very big numbers. I don't know if any of you would disagree with these, if these resonate with what you're seeing in your facilities, but pretty high numbers. No surprise, right, that the most recent survey said that prior auths are the #1 reason for denials at 48%. I'm sure that isn't a surprise at all. I also read an article that said that prior authorization is almost universally despised by physicians and patients. They actually use the word despise. I thought that was a very strong word, but I think we all despise the prior authorizations as well. They're saying that prior authorizations is one of the most time-consuming parts of the revenue cycle management task. So need to get a handle on it. Now, many institutions, many facilities are looking to automation. We have been assisting with automation as well at Extend to some of our customers, and it is making some improvements. However, again, you still have to have that human behind it as well. It's not 100% at this point. There are other things, obviously, that is a top cause of denials. You got your provider eligibility, your code inaccuracies. I hate this number because, again, being an HIM person, I want to think that number should be really low. The reality is it's 42%. That's pretty high. Incorrect modifiers. A lot of that could be your charge master. We do run across a lot of facilities that don't really have an updated charge master, and those rules are changing left and right, especially payers and state to state could be different as well. Timely filing, this one drives me crazy. I don't think that there should ever be a timely filing. One of my facilities I worked at before I worked at Extend, we had a very rigorous timely filing. I'm like, this is insane. Nothing should go timely. But the reality is when you start doing a drill down, then you kind of figure out, well, guess what? It laid in someone's in basket for it. Here I am, paper world, right? But it laid somewhere that we didn't even get to it. So it's the reality, unfortunately. Patient inaccurate information at 34%. And then, of course, missing and inaccurate claim data. That's pretty big. Yes, do you have a question? Correct. He was saying that the patient inaccuracies is mind-blowing, right? That shouldn't happen. But I've been arguing this for over 30 years. The patient registration, you've got to explain to them what their purpose is, why this is so critical to get the right information in there. I'll tell you a story, probably a little earlier than I wanted to, but 10 years ago, I had a female procedure, and 2 months later, I got a bill from the hospital for $37,000. The whole thing had been denied. And this is 10 years ago. I didn't even really know what denials were because it wasn't as big of a thing. I was freaking out. I didn't have $37,000, and this was a medically necessary procedure. I called the hospital, and they're like, oh, well, you know. And I'm like, whoa, wait a second. Call the insurance company, and they're like, and I'm like, okay. So I got both of them on a call, so it was a three-way call. Found out I was on my husband's insurance. They had registered me as a male. Now, first of all, how it got through a scrubber or an encoder that I was a male and had a female procedure. Okay, males couldn't have this particular unless they have ovaries, but they don't. So how that even got through their scrubber 10 years, I don't know. But the patient, had to be my own advocate 10 years ago to get that figured out. Switched it and boom, taken care of. Inaccuracy in registration. My son worked in a very busy level 1 trauma center, ER, in Denver for quite a few years. When he got that job, I panicked. I'm like, do you know how important it is to register the patient correctly? He's like, Mom, I got this. I'm like, no. Do you know how important it is to register the patient accurately from everything? And he's like, and I'm like, no, you don't understand. And don't create a double number. If there's one John Smith, there's one John Smith. Make sure you're getting all that. It's critical. But it happens all the time. It's just, or I like it when someone asks me for my insurance card. I want them every time I go to the doctor to ask. My dad's like, why do they ask all the same information every single time? Well, for him, he's on Medicare. It's not really going to make a difference. But I want them to because people change jobs all the time now. So maybe that insurance isn't correct. So is it really that big of a deal? But I don't think people understand if you get that little bit of information wrong, it upsets everything. So good point. I could go on and on with stories. That's what an HIM professional does. We have lots of stories. I'm sure you all do too. Again, what are the factors in this? And they said that, again, lack of denials resources. We talked a little bit, we've talked about workforce. There's just not enough folks out there to fill these positions. And they said that there's so much turnover and they just can't hire the right staff. And once again, to your point, you don't want to hire someone who's not going to have those critical thinking skills, have attention to detail. We've got to hire the right people to do that, and there just isn't that pool out there. So the increase in denial sometimes is the resources. And then we talk about the staff attrition and training. Is there a good training program? We'll talk about policy in a minute. But growing denials backlog. Because of all this, there's a backlog. And now you start adjusting things off that could be denied because you just don't have the staff to be working them all. Payer policy changes. This one I added this recently because between March of 2022 and March of 2023, there were 100,000 policy changes by payers. So again, having the right staff to follow those policy changes, making those updates in your policies and procedures and things like that, it's critical. Now, of course, that's not 100,000 for every facility, but there have been a lot of policy changes. And then, of course, there's pre-auth tracking, and technology changes also are some factors. As I said, 67% say that the policy changes are occurring more frequently. They are. I mean, we used to have since 1983, that's dating myself, but in 1983 is when DRGs came into effect. And then you would have new codes, ICD-9, which is only like 80,000 codes. But you had new codes come every October 1 when the government fiscal year came. When the pandemic hit, and we've had that forever and ever and ever, pandemic came, and now what do we have? We not only have code changes every October 1, we have code changes every April 1. I have a hard time, quite frankly, remembering that. I have to put it in my calendar because I've had October 1 in my head since 1983. And now here I am having to remember that, oh, we have another code change April 1. Let's make sure our coders are up to date on that April 1 change because it's different and new. They're usually not a lot, but enough that you make sure that you're educating your coders. So when you talk about policy change, that was a policy change that came out of COVID. We were glad then. We thought it was a one-time deal because we finally got a code for COVID that we could actually track it. But it's now continued on. Reimbursement is taking longer, as we all know. Your over 90 days might have grown. If it hasn't, good for you. But it's partly due to denials. Again, there's an increase in the claim submission errors. Hopefully you all are not affected by that because I know this group is probably, we don't have that problem. But then, of course, there's just this over increase in denial. Now, this is the slide that I almost took out, but then I'm like, every time I take it out, I probably underestimate or overestimate things. But it's important to know when you're going to do prevention what your current denial rate is. Where do you stand in denials? And when I go into a new facility, I always ask that question, what's your denial rate? And I'm surprised that they don't know. Usually they say a lot. I don't allow that word for my staff or my children or my husband when they say a lot, because a lot's not a number. I want a number. I want to know, what is your denial rate? And what is your whatever I ask? If my staff says, well, we have a lot to you and a lot to someone else may be different. So I want a number. And I'm surprised at how many times they don't know what their denial rate is. So we go digging into calculating that denial rate. And when you have that kind of specificity, you know where to start. You know that where the root causes might start. You might want to start for those root causes. And that's where you discover your opportunities for improvement. And then you can also define the size. If your denial rate is low, and we'll talk about what's acceptable, best practice is perfect practice is under 3%. Good practice is 5%. Most folks have around 8 to 10%. As we said. So probably most room for improvement. Now, if you're below that 5%, pat yourself on the back, applause, that's outstanding. And we can all learn from you, and you should probably be up here, not me. But you first got to start with knowing what that denial rate is. And I also want to say this is the initial denial, so that initial denial rate, because there are, the secondary denials as well. And those are all important numbers to have also. But then also your dollar rate. This dollar rate, the percentage of denials might not mean much to some people. It means much or a lot to us, but it may not mean much to your administration. So having a dollar number behind that will get their attention. So you calculate that denial dollars as well. And then, of course, what's your appeal rate? How many are you really appealing? And they do say best practice is 85 to 88%. Now, there's an argument. We have a couple of facilities that want us to appeal 100%. And there's that argument, Wayne Gretzky says you miss 100% of the shots you don't take. The reality is that probably at least 10% of those, you're just not going to win. And there are some that when the appeals nurses and our appeals team, when they calculate, they will put in their strong support appeal, strong appeal weak, and then none, unless they've been told to appeal 100%. Some, people always say, oh, it met timely, don't do it. Some of those timelies can be overturned, but some can't. So you've really got to have a crack team to know the difference there. But I always say, about 90% is probably the good number to shoot for, and that's what we've seen as best practice as well. So there, you have your denials. Now you know your numbers, you know all this good stuff. But make sure you know the difference between the technical denials and the clinical denials, and the or technical denials are non-medical reasons, of course. Like it might just be correspondence for medical records, itemized bills, and other documentation. What I find interesting too is when you get a denial and they say, I want the itemized bill and the medical record, and facilities do not match the two together. They send the itemized bill and then they send the records. That's just one more reason for the payer to go, I got the records, but I didn't get the bill, or I got the bill, but I didn't get the records. Back in the day when we used to mail appeals, they loved to say, no, we never got it, never got it. And I'll share this with you, which no one needs to use this anymore, but I used to get so angry when we'd get a second request. We never received it. It's like, oh, really? So you send it a second time. Well, we don't have it. I'm like, you know what? I only did this twice, and I kind of fudged a little bit, but I was the privacy officer, so I felt okay by doing it. But I called him up and I said, guess what? We've sent this to you twice. We've sent you medical records and itemized bills twice, possibly even by certified record. You can't find it. You're in violation of HIPAA because now you've got records floating all over your facility. That's kind of a stretch, quite frankly, but I hope there's no payers in the room, but it worked. Oh, look what we found. I always wanted to do a tour of some of these payers back in the day and see where all these, we probably had a room like this just full of paper records. So thankfully, we are in a good place with electronic, and portals and things like that. We do send some paper sometimes, but it's good to connect everything together because then there's no chance, well, there's still a chance they're going to say, we never got it. But if you send it together, there's not quite the horrible chance that they're going to say no again. And then, of course, know the difference between your technical and clinical appeals. That's why it's good to have a team of folks who are interested, from the medical necessity, length of stay, level of care, and coding. All those can be more of your clinical denial areas. These are some examples of denials that typically, again, nothing's 100% here, but typically require an appeal. Things like days in service denied for no concurrent auth. If there is a patient in-house, for example, needing a concurrent auth, have a good process, policy and procedure written that folks follow. Is that case management who's calling and getting that concurrent auth, and what are you doing with it? How are you documenting that? A lot of the loopholes is that it wasn't, you got it, but you didn't document it appropriately, then you have nothing to fall back on when you do that appeal. But you can fight these, and in many opportunities, it will get overturned. Of course, we talked a lot about timely filing. I don't want to get into that because, again, I just shake my head on that one. But I think when you do your analysis, which we'll talk about in a minute, when you do an analysis, you can understand how it did make timely filing. Maybe it wasn't a covered service. A lot of those, just because they say it's not covered, have you looked at the managed care contract? Is it really a non-covered service? Maybe the charge and procedure weren't bundled appropriately. That's could be a charge master issue. Make sure that charge master, I'm going to say this probably 5 times, make sure that you're always having the charge master updated and that it's current. A good charge master audit once a year, whatever, by either an external or internal group is ideal. I know that none of you are in this category, but we've been in places where the charge master hasn't been updated in a long time. And I'm not going to say how long because it kind of isn't a good number. But I'm sure none of you are in that. And again, you have some that are additional information, pending receipt of the records. We talked about that and the incorrect information. This one is just a reiteration of other things, but just reminders that this is reality, unfortunately. We got to start somewhere when you're going to start a prevention program, and you got to start with data. Data is very, very important. With the increase that we've seen over the last few years, if you don't have that data, starting with your appeals rate, if you don't have that, you don't even know where to start. So if you're going to identify a root cause, what's the data say? What's in there? So use that data to trend and identify the low-hanging fruit maybe, or the bigger issues. Document and trend those, and then identify in patterns. You also have to have this to show your success. Because if you don't have administrative support to maybe even start a interdisciplinary team, you got to show the data and then show your success, because you will have success on that. Identifying the patterns, sometimes you can start with your CARC codes, but you can't just depend on that. You do got to do a deep dive and a drill down. This is stuff I love to do. When you're analyzing I love to analyze DNFC and DNFBs. Why are we having these issues? But this is also critical data to drill down and to see what's really going on. So start with data, have the right data, and you can't ask for too much data, really, because the more data you have, the more you can do a deep dive. So one proactive approach that's essential for identifying those root causes and can get into from management to prevention is collaboration and creating a multidisciplinary team that is comprised of multiple departments. I won't read them all to you, but all these departments to meet regularly and discuss the root causes and how to permanently correct them. This is like old total quality management 101. You could put a team together, and some of these departments are going to say, why are you inviting me? I have nothing to do with this. And you'll find that it's like, bear with me, just please come, because number one, they're going to learn something. Number two, they're going to figure out, oh my gosh, I didn't know that when I did this, it affects this. Back to the patient registration errors. They didn't realize how just that one little thing has a trickle-down effect and how it affects the claim. And of course, patient care as well. But meet regularly, identify those root causes, and again, the resistance might be there, but gotta hang in there, and eventually everyone will be engaged and will get involved. There was a study just done, I just came across at the beginning of this year from the National Association of Healthcare Revenue Integrity that said that there was a study, I don't know why that changed, but they said that when they put a team together like this and had ongoing work groups and things like that, that 63% of the time they saw improvement. And so it went from management to prevention. Again, we're not going to solve this until maybe we get in Congress or something, or we change our healthcare payer system. Not in my lifetime, most likely, but it does work. It does have a very huge effect. So including all these people, I remember I used to get invited to, again, this is how it's showing my age, but I used to get invited to TQM teams, like in the pharmacy. I mean, like, what? I don't know anything about pharmacy. And they're like, well, we're not exactly sure why you're here, but you usually know something about what we're going to talk about. And so sometimes, it's like, oh, okay, and then you learn something, and you find, oh yeah, I might have that one bit of information that's going to be critical to the big picture. So hopefully you can get buy-in if you decide. Does anyone have any multidisciplinary teams in their organizations who are looking at that? Great, and is it helpful? Oh, good.
Sorry.
She's from Patient Access, so you don't have to repeat. Go ahead.
Okay. Long story short, yes, we do. And
Okay.
I can talk loud. We do have a denials governance committee at our organization where we partner with different teams to look at those specific
Good.
in our Oregon Health Plan. We were able to implement some prior auth implementations around devices and those denials specifically. So we definitely saw an increase or a decrease in our denials in volume and dollars.
Wow, that's awesome.
And we continue to do that every month.
So getting that interdisciplinary team, managed care, that's one of the people on, let's go back here. One of the people on there, I thought it was managed care, and you might wonder why managed care should be on that. But to your point, you don't know sometimes what's in those managed care contracts. And so once you start delving into those managed care contracts, critical. And then what was the next one that you said with managed care? Oh, you did deal with the payers to figure out what they were looking at. And you could just do this talk. She could just be up here now and do this. But I think it's important that you do meet regularly, because there's going to be things that keep coming up, and you have seen your denials rate lower, you said, get less. That's great. Prevention is where it's at. That's awesome. And did you say something about, you didn't say anything about experimental drugs, did you? No, that's something that we are seeing a lot, that we have been successfully getting past the experimental drugs. Maybe not 100%, but experimental drugs is something that this team, that one of our facilities put together, that were successful in with some of the experimental drugs. So that was good. Just talking to the payers. A lot of time is just getting the payers involved as well.
We also,
No, please, please. We have an hour and a half.
also use some of the root causes around registration errors to implement an optimized training program for our new hires.
Love it.
Where their QA scores coming out of that training are over 95%, where we started in the low 60s across the organization. So we put everyone back through that optimized training and are seeing a significant increase in our QA scores across the board and patient access errors.
So patient access, it gave them an opportunity to build a patient access education and training series that they have to meet 95% or higher, where you started about in the 60s, I said, and so you've seen significant. And again, it all starts in patient access, in many cases, that you got to get it right. So that's wonderful. That's great. I wrote down your Denials Governance Committee. I love that name. I'm going to use that. I'm going to take that from you. But I love that name, because that is exactly what it is. And I would think that this is an ongoing committee that you'll have, because as soon as you solve something, the payers are going to come up with something else to ding you on, right? Well, that's great. Thank you for that input. I appreciate it. Again, I'm sure maybe you did or didn't do this, but reviewing workflow is critical. Once again, understanding the scheduling, authorization, and medical necessity. They said that in many of these authorizations weren't necessarily authorizations as much as medical necessity, because those two go hand in hand. So you got to really do a drill down when you look at those scheduling issues. Surgery scheduling, for instance, and authorizations, they kind of go hand in hand as well. One of the best practices that I came across from one of our facilities is that surgery scheduling does look at the CPT and compares it to the auth. So they have a little bit higher level there of scheduling. And if it's not, they go through the code and they meet with either coders, or they have information that they can look that up and make sure that the auth and the procedure are accurate, because so often you get the auth for one thing and then the procedure is something different. And I'm glad my son is never going to come to these, but the son who worked in patient access or in the busy ER, now he's working in pre-scheduling and for a facility. And again, I'm like, oh, Lord. I'm just like, please do a good job. Do you know how important this is to get it right and everything? So I'm waiting. He just started, so I'm waiting to get more information and pick his brain a little bit about how they're doing their training at the facility that he's at, because I think we can all learn from that. And again, schedulers working with nursing and providers hand in hand is really very, very important. I sat with a someone who was doing prior auth or pre-auth, and she was just looking up codes on the internet. She didn't even have the books, didn't have any of that. And I was like, oh my gosh, like, why aren't you doing this? And she's like, well, isn't this the CPT code I need? And I'm like, oh my gosh, it was, but sometimes that's the only resources they have. So I've seen a little bit of the best and the worst here. But then also looking at your workflow, again, patient access, how are they getting the auth? It could be something as simple as, are they even documenting the pre-certification number? And if they have gone back and forth even with the payer, document as much as possible. Document, document, document. The more you have in there, if it does get denied, the more you have to argue your appeal. And my nurses who do appeal letter writing always say, we don't have any information. Or, this information is great, it will get overturned. So the more information you can get up front, and that the schedulers and the patient access, the more they can document in that patient record, the better. And of course, knowing covered services, then of course, even patient care. The physician documentation, CDI, include them. They're not case managers, different. I'm going round and round with one facility that the physician who's been there forever thinks my CDI people are case managers. They're not, but they know the clinical documentation and they can work side by side in collaboration with case management to ensure that the documentation is there and that the case manager and them can work together to make sure that things aren't documented incorrectly and it's complete. Now, again, complete quality documentation. And then, of course, for medical necessity as well. Then you get into the HIM and charge master. We'll go into a little bit more of that in a minute. Documentation is critical, of course. Your charge master, your charge capture needs to be accurate in coding. And like I said, we'll talk more about that in detail. And then all the way to billing and patient accounts. All these pieces, you need to review each piece of those. This is, like I said, this is just old school root cause analysis. So again, we talked a lot about the front end, the pre-cert, the authorizations, the non-covered services. And are you giving the patient the ABN? I hate that because I don't want the patient to ever have to feel responsible. However, there are some cases that if you've talked to the patient and explained to them that this is not a covered service and you've given them the ABN for their understanding, then that's a little bit better. Like I said, I wish patients didn't have to pay for all of it, but and again, we'll go into the invalid insurance information, and I've talked a lot about that already, and the ID, so I won't bore you with. I could probably come up with 5 or 6 more stories about the registration issues because it just drives me crazy. And then a patient access, we talked a lot about that. Thank you for your input there. Again, the ABNs, the pre-certs, it's just document, document, document. And then your ancillary areas we talked about already. Clinical documentation, make sure it does support the level of care, as I said, and that it's in a timely manner. Physicians, we all know I've chased down physicians just to get their records done, right? Not as badly right now, but they don't really like the electronic record any more than they like the paper record. They just want to practice medicine. But unfortunately, we need all that information. And we need to communicate with the physician when the stay doesn't meet the coverage criteria. Are we having those discussions with case management, CDI, whomever? Are they working together to make sure that they meet that criteria so that's not, I don't know why this is automatic, meeting that. Also, that what are you appealing? Make sure that you've got the data on that, and that discharge planning starts at time of admission. That one we kind of forget about because you think, oh, they're just admitted now, but length of stays are so limited nowadays that you've got to start that discussion at the time of admission, unfortunately. And my dad was just in the hospital last week overnight. And I was just like, the first thing I thought of was, oh my God, is this going to meet medical necessity? And I'm like, oh Lord. Well, I'm supposed to be worried about him, right? 86-year-old man dehydrated. And I'm thinking, oh gosh, what's his labs? What's his this? And I was thinking totally payer when I shouldn't have been worried about that, but unfortunately I was. But again, including those folks is critical. And let's talk a little bit about coding, right? Documentation issues. If there is a breakdown with your clinical documentation, like missing times, there's a lot of detail in there, that could really cause some decision-making disputes. So again, make sure that all your documentation is credible, of course, but accurate, but it's there timely as well. And there are still times that we don't have all the documentation even at time of discharge, and we're waiting for that. Don't code something. I don't tell my coders to code something, just number one, not based on what CDI did. CDI people are not coders. No offense, some are, but you need that. I don't know how this got on automatic, but you have to have that coder take a look at it post-discharge. 100% of the records need to be looked at. Don't depend on your computerized coding system, CAC. Don't depend on that. Have your coders use their critical thinking skills and everything that they've learned, because it's very, very important. And your coding, and if you do a coding analysis, you can look for patterns of what's going on in coding. And again, as much as I don't want to say coding is a big problem in this, unfortunately, what we're finding is that, if coders haven't been educated on a regular basis, and I do have some, for those of you who are interested, have a couple of really great coding education companies out there that I can share with you that do a great job. We mandate our coders take all these courses. We actually provide provide the education for them. And because an educated coder is critical. Just because they might have a couple initials behind their name, they got to keep up to date. These codes are changing, the rules are changing. It's very, very important. Very important to have regular audits on your coding staff. And make sure that they understand what different edits mean and how critical those are. We have a whole coding denials team. And that seems to be, in many of our facilities, some of the greatest areas. They'll say, yeah, we've got about 4,000 claims that are just kind of sitting there that need just a coder to look at. Okay, let's get on it. That's just money just sitting there that needs to be looked at, and you need a coder to do it. So you got your many coder issues. CCI edits, like I said, make sure they understand them. Make sure your scrubber, everything is up to date. There are also DNFB edits to look at. And then you've got your DRG validations and even your DRG downgrades. Take a look at all of those. Don't just accept something. You get your remittance advisement and they do a downgrade. Don't accept that. Years ago, I had a job, that's all I did is look at every remittance advisement and compare it to what we billed to what they paid, and then we could dispute it. Don't just take what the payers say is golden. Definitely have your coders very involved in that. And then, of course, like I said, incomplete and inaccurate documentation. The incomplete documentation still bothers me. It's like, come on, it's electronic. It shouldn't be that difficult. I literally used to chase doctors down the hall to get them. They used to run from my mother, right? They hear her little heels on the floor. They'd be like, oh, crap, here she comes. And she was all of 5 foot tall. And they'd run because she was going to suspend them. They didn't get their work done. But we got to have that done quickly, especially because turnaround times are just ramping up. Most of my facilities have maybe a standard delay or the 3-day, 4-day hold, and they want that claim out the door at that day 4. I get it. I totally get it. But we got to have that documentation in there first. Yes?
So, no, oh, here. Great, thanks. So, when you're running down the doctors, do you run them? Is it? I mean, like you said, a lot of them run because it's like they're just hassling me to do this. Should we even be giving them 3 days? Because I'm going back to patient care. So if I get discharged from the hospital for whatever procedure I had done, 3 days later I may be somewhere else, a different caregiver. My incomplete undone documentation is sitting somewhere else, and my caregiver currently is where. That's not my job as a patient who's under care, and probably not in a place to provide that. So do you really, is that the conversation you have with the physicians and say, when John gets discharged, he does not get, I would love it if you had the ability to say, John does not get discharged until you complete documentation. And if John stays the extra day, it comes out of your pay.
I totally agree. They all go by the Joint Commission rules, which is 30 days. Okay, you tell me one CFO that's going to allow a bill to sit there for 30 days while they wait for a discharge summary. That's just not good business. But it's also, to your point, not good patient care, because now you've just been a follow-up in the doctor's office from a stay that you just had, and you have no discharge summary. Because hospitalists are seeing, and yeah, you can see the chart probably, but you still don't have that discharge summary, or a consult maybe, or the procedure note, So, procedure notes are supposed to be done immediately following surgery. I got yelled at by a physician one time and said, Colleen, he was a heart surgeon, he was phenomenal. And he told me, he goes, Colleen, if you ever ask me to do a procedure right after I've walked out of that OR, he goes, I'll just walk out of this hospital. He goes, you don't understand that I was probably in the OR for the last 15 hours. I may have almost lost a patient, whatever. And he goes, I'll do it. I'll do it within 24 to 48 hours because I know what I did, but don't ask me to do it immediately. And so from the human perspective, but at least by the time of discharge, to your point. I haven't seen too many facilities lately because electronic doctors are better. They've been very good about documentation. It's very rare, or not like the paper world where you literally did chase them down. They're getting them done quicker, and I don't see many penalizing them like they used to. Some facilities still use the suspension, if you're X number of days, you're suspended. Or some other facilities fine them. That's not real popular with physicians. I just took food away one time, and you thought that I chopped off their arm. I used to give, I paid $10,000 a year back in the day for food, for breakfast, for lunch, for afternoon snacks, popcorn. And when I took that away slowly, you would have thought I was the worst person in the world, just to entice them to come in and do their paper records. Again, dating myself. And they can do it from home now. So I have seen those vast improvements, I will say that. And your chronic offenders, you need administrative support to get them to do what they need to do. But good point. I could go on that forever. I've been called every name in the book. I've had doctors in my office threaten me. I've had, literally, back again, this is paper world, but I've had really bad threats to the point where I've had to go to administration, and administration has had to, do some sanctions, because there's a couple times I was a little worried. Most of the time, not so much, but because they're just idle threats because they're the doctor. But it's getting better, much, much better than it used to be in the paper world. But that has to be, because guess what? We've got to get these bills out the door, and patient care. Those docs, when you go, they're not expecting to see paper. They're expecting to see it on the screen. So that's a great point. Thank you for bringing that up. Again, some of the things for coding, and I know that many of you may not be over the coding area, but I do think this is really important. And I did just speak a month ago or something to a coding group regarding these. And just remind your staff, if they don't report to you, maybe take this slide, or just remind them to code to the highest level of specificity. making sure that you are capturing those CCs and MCCs. If you don't have a CDI program, think about it, because those CDI specialists should be looking at most of your records, if not all, and looking for those CCs and MCCs while the patient's in the hospital. But if you don't have a CDI program, your coders need to be capturing that information for higher reimbursement, but also for statistical purposes. You need that information. So definitely code to the highest level of specificity. And look for, it's missed documentation opportunities. Focus on those DRGs that we know have the CCs and MCCs. Many places will also differentiate between your MS DRGs and APR DRGs. Remember that those length of stays are different. And so understand the differences of that, especially if you have a CDI program, work that into it. Because those geometric mean, or those GMLOSs, that's important in the long run, especially for your case mix too. And again, have a robust query process. And to your point about clinical documentation being complete, hold the docs to a standard. They should be responding to you in less than 24 hours about that query. And if they're not, why? Find out why. Now, a lot of physicians get query fatigue, we call it. My CDI specialists call them love notes. Hey, doc, I sent you a love note, and try and humor it a little bit. But if you have a good, robust query process that you just are ensuring that all those CCs and MCCs are there, that's great. You don't want to overcode because that's not compliant. And make sure your CDI folk and your coders are not doing leading queries. We could do a whole talk on query writing, right? And there's some great articles out there from AHIMA about query writing and compliance, and ACTIS also has some. So make sure that query writing is quality and compliant. I've seen some places that it's a little leading, and you got to be very careful with that. That's not cool at all. And of course, productivity is important, but I'm always going to stick with it. I'm an old HIM person. Quality is the key to all of this. Having quality documentation, quality queries, the whole process, quality coding. If your coders aren't at 95% or higher, we put them, our coders, that's our expectation. We're at 98%, and that's kind of our new norm now. But we audit them monthly, 100% monthly. That should be done. It's hard to do that. That takes extra staff. But at a minimum, I would think once or twice a year, you need to do an audit on your coders, like a third-party audit, if you don't have the infrastructure. But make sure that they are continuing to learn, especially focused on whatever the OIG might be focused on right now for audits as well. I mean, that's a whole nother talk we could get into. But I did want to bring it up because it is important that coding is probably one of the most critical pieces to denials prevention. And of course, I'm always about continuous improvement. I don't know if you guys are probably always measuring what's working, and then you might have to tweak something. Something changed just a little bit, but you need to tweak it. But continually monitoring, like I said, the coding and billing processes for opportunities to improve your accuracy and efficiency is key. I talked about the regular coding audits already, but make sure that you are constantly reviewing and analyzing that data and working together with everyone. Again, the coding audits, like I said, is critical, but then making sure that you're educating your coders. Sometimes we forget about that. And so again, I have a couple names of some great companies out there who do education. We've used both of them, and they're wonderful. And we mandate X number of hours per year of coding education. They have to keep their credentials. They have to be credentialed, first of all. And then not just keeping their credential through AHIMA or AAPC, But on top of it, we're requiring additional education because things are changing so rapidly. And we just want to make sure that they're staying at that 98, preferably 98%, but 95% or higher is what our requirement is. You also want to maybe focus on specific areas, sepsis, respiratory failure, AKI, severe malnutrition. All of those things have major CCs and MCCs. They're also ripe for audits from the government or from your payers. And they are ripe for areas, especially sepsis right now is a hot topic, so is vents. But make sure you're doing even focus reviews on those. Once we started doing focus reviews at a couple of our facilities where we're doing all their coding and CDI, when we started really focusing in on that, there was lots of education opportunities, a lot of query opportunities as well. So, and having those CDI folks who are very clinical, along with your coders, getting them together, we meet at minimum once a month with the coders and CDI, and do like an educational type of discussion. Even if it's 30 minutes, pick one case, maybe two, depending on the severity of it or how critical it was. And both sides are learning from that. So again, takes time, everyone is busy, but that 30 to 45 minutes once a month has really made a difference. So just another idea. And if you get PEPR reports, to look at performances from other facilities in your area, things like that. Use that as a comparison as well. It's a lot of great information. I never even knew what PEPR reports were until about 10 years ago or something. And I'm like, this is a wealth of knowledge that we have if you do get those. And I skipped over, be prepared to debate with the payers. Having a really good discussion with them so they understand you and you understand them is very, very critical. You might also want to include information technology and compliance into your work group. And the reason I say that information technology is, it is amazing to me how often I run across the opportunity that in the interface wasn't working for just something, an interface between two systems, or that they weren't updating something in a timely manner, because we're getting constant updates. Just make sure your information technology departments understand how critical it is to do this in a timely manner. And then compliance, I can say audits all day long, but to get compliance involved also just to make sure from another perspective, to look at that charge master coding, all those different areas to make sure they're compliant. I want to get real quickly, that's kind of your prevention. You put that together, you get that going, that's great, but now you still have to write appeals letters, right, in many cases. So you do need a strong appeals team who can respond to the denials, not only from a quality perspective, but timely. So once again, you only got so many days to get that letter into them. We talked about the 85 to 88%, up to maybe 90% of denials, appealing denials as best practice. So you've got to have the right FTE complement as well. So that's why it goes back to how many denials are we getting? What kind of denials? Are they technical versus clinical? And a good, oh, I hate this, a good nurse, or well, it doesn't have to be a nurse, it could be a lot of different disciplines, but a good clinical review specialist, appeal specialist, whatever the title you want to call them, can usually do about 5 in an 8-hour period, maybe 6. Again, it depends on the complexity of it. Maybe they can do a little bit more. Some of them may take a long time to write it too. But make sure you have the right FTE complement to complete these. And there's a skill set to it. There's definitely a skill set. Here's just some tips. Appeal every case where there is obviously documentation to support the original coding and the billing that is in there. So thoroughly review it for the validity of the denial. So make sure that whoever is writing that appeals letter or looking at it, or even just reviewing it to see whether we can appeal it or not, that they have a thorough understanding of the coding and of the documentation in there. You know, it might be based on clinical indicators or a coding error and things like that. They have to understand that. I actually there's resources out there. One of them is called Up to Date, and it has a lot of the clinical indicators and things in there, and that's what our nurses use to write letters as a resource. It's an additional resource. And, you know, again, we talked about not every case should be appealed. You know, I mean, you can, if that's what your philosophy is, you can try it. But there are going to be some that you just aren't going to be supportive, or maybe partially supported. But make sure that you have all this information in there. Include your clinical coding expertise. So if you have a coding clinic, if you have documentation from any resource, put it in there and put the resource in there. You also want copies of the record where it's appropriate. Don't give them the whole record. They don't need the whole record, only that piece that you're helping to appeal. And again, the official any kind of coding guidelines is a big deal. And then the credentials. If you had a physician help you review this, a pharmacist, a nurse, whomever it was that helped writing it, put their names with their credentials in there. That is important to show credibility. Sounds crazy, but it is so true. You know, you rarely have to get physicians involved, except maybe to a peer-to-peer eventually. But when you do, if there is something a little dicey you want to get them, put that physician's name and credential in there. It's really, really important to do that. So these are just some tips. One of the talks I gave, they said, hey, could you give me some examples? And no, I can't, unfortunately, because there are a lot of PHI and a lot of stuff. But there are some things on the internet. I also was asked recently to use ChatGPT for these. I see you nodding your head. We tried it. It did not work. Now, there's probably systems out there that are more clinical than your typical ChatGPT, okay? I'm sure it's going to come about, and maybe there is something we haven't found yet. But we had two of my more seasoned RNs use it, and they said it ended up taking them a longer time than usual because it doesn't have the clinical piece yet. So they have templates, but they're very, they just don't plug in or cut and paste, of course, because every case is totally different. But the ChatGPT just didn't work for them. Did you have a different experience that it did work or it didn't work? I saw you nod your head.
No, I was nodding because I appreciate it. I was nodding my head because... You can hear me? Okay, there we go. Yeah, no, just nodding my head because I can see that that's a direction that I think we're going to be going and interested in going in to save on time. And I think as the sophistication improves, I would expect to hear more about that. So I was agreeing with you.
We're going to try it for some of the very easy technical denials, some of the very basic stuff. But even that, it's not perfect yet. But definitely the clinical denials, it just didn't work yet. AIs, we're all going there, right? But appreciate that because, of course, I had people say, Colleen, you should try this. It's going to be great, And, of course, my kids use it for stuff, And I'm just like, it's not clinical enough. And after I said no, then they said, you have to try it. So we did, and it didn't work yet. Now, I could be here in a year from now and say, hey, there's this great software out there, and that might be an idea for any of you entrepreneurs out there. But I think we're going to find it someday, but not yet. So the other thing I want to mention, too, is measuring success. I find it interesting that you put these teams together and you do all this work, but then you don't measure your success, and you do have to celebrate that, right? So tracking your total number of denials, your appeals, cases that you didn't appeal and why, because that can be trending data also. Could be a particular physician, could be a particular diagnoses, things like that. Also, total cases overturned and what the financial impact is. That's a more difficult one sometimes to track because you've really got to stay on top of it because you don't know when it's going to get overturned or you're going to get, or not overturned. You got to keep following up on that account by account, to see what's happening. So it's a little bit more difficult, but I get really upset when I'm like, well, what's our overturn rate? I don't know, we didn't track it. It's like, well, how do you know if you have success or not, or what you need to really focus on if you don't know what your overturn rate is? And then, of course, track your second level denials. And of course, even failed appeals, that's okay. You're not gonna get 100%. But what are those failed appeals and why? Is it one payer? And I won't say any names, but we probably all have, I don't know, Oregon might be different than Illinois, but in Illinois we've got one payer that is up there on the, you gotta go a second and third time to appeal. But having all this and tracking it is really critical because, again, you know where to educate, you know where you need to put the resources. You also share this with administration and show them that it's working, that it's a really good thing that we're doing this, that we're getting coders educated. We have a training program in patient access that we've done all these things because our denial rates have now gone down, like in your situation. So I find sometimes we do all these things, but then we don't track them. And then we might have to tweak some things, and that's okay too, because it is an ever-changing world. But it is really critical to track and measure your success. Everyone loves graphs, right? So every time we put these together for administration, we always have to put graphs together just to kind of show what's going on. This is a very, very elementary graph, but so simple to show like what the impact might be, the types of what we're overturning, what we're appealing, what we're not. And I have a whole slide deck of multiple examples of this that I didn't want to share with you today, but I didn't want to bore you actually with samples after samples, but I can share them with you if you're interested. But let me get back to that. But something this simple that you track and show every month. This is what we provide to facilities on a monthly basis of what we're overturning, and we can look at trends and things like that. So I think it's very appreciated when you do have this information. Plus, I'm always asking those questions, as I love data. So again, transitioning to breaking down the causes, identifying those causes, the root causes, doing the education where you need to, might be all areas. And also that, tracking your success, things like that, continuous improvement, collaborating with payers, communicating, and educate everybody, front, middle, back, right? Not just the front, patient access. Yep, you can start there, educating the coders, but educate the billers too. Like I said before, we found that there was one facility who was they weren't even digging deep into those denials, and they were just going, we'll just write it off. No, don't make that adjustment. Don't do that. Let us take a look at it. So again, we don't want to be adding time to the payer. We want that cash in the door, right? That's what we hear at every facility we go to. We need cash. Well, the way to get cash in is one way is to get these denials reduced. You're never going to have them down to zero. So working denials within the 48 hours and having a defined procedure, getting those letters written is just critical. So again, in conclusion, consistent and timely review, ongoing communication, the successful appeals, letter writing, and then measuring your success. And again, I'm going to say tweaking where you have to, because as soon as you find something that works, it might be great for a while, but something else might come up. So make sure that you are measuring your success and then moving forward. And celebrate your success too. Any other comments from anyone? That's all I've got. I did talk a lot more than I expected, but surprise, surprise, my husband would say. But any other comments from any of you? Anything that you've done that's been very successful in your areas? Yep, yeah.
So just to tack on to the educational piece, when we
He's bringing you the mic.
Can you hear me?
Yep. Go.
Just to add on to the educational piece.
Can you guys hear? Oh, good, okay.
After we piloted the optimized training program with our patient access staff, we extended that out to all of revenue cycle. So we now have the optimized training for our billers, for our coders, for our CDI team. And we've really collaborated with all of those partners with our training team that is dedicated to the maintenance and upkeep of any changes within those different areas. And then we created a continuing education policy with all of those teams as well to make sure that we are consistently providing that education. And that has worked well in all of those spaces.
I think education is key. I mean, because again, you think you kind of know, but when you really delve into it, maybe we don't know so much. So again, thank you to Oregon. I've never been to this state that I can remember. I find it a great drive from Portland down here. I greatly appreciate you inviting me today. And if you do want additional information, just let me know. Thank you so much.